As we know, today's didactic will be substance and sexual dysfunction, and Dr. Arun has helped me in coming up with this presentation. Let me start with a study from Arun Center, which was done in 2007. It was a checklist-based study. The checklist was arrived at by looking at the ICD-10 criteria for different sexual dysfunction disorders, and the checklist covered 12 areas of sexual dysfunction. It was administered to 100 male subjects who came in simple withdrawal for alcohol dependence. The mean age was 37 years, and their ages varied from 25 to 50 years. And interestingly, about 72% of them at least had one sexual dysfunction, and 48% in the total had more than one complaint of sexual dysfunction, which really speaks of how prevalent is this problem among the patients whom we see on day-to-day basis. And of these, premature ejaculation was the most common with 37.5%, loss of desire or loss of libido was 36%, erectile dysfunction was 33%, and 14% had anorgasmia as one of their complaints. With this background, let me go to today's presentation proper with I'll start with a brief recap of what sexual dysfunction means and the normal human sexuality. And then I'll be talking about the problem statement, which is basically to look at, similar to the study which I talked about earlier, studies across the world which have linked sexual dysfunction and substance use disorders. And then we'll briefly go through substance-specific reviews, how each substance has a role in sexual dysfunction or sexual function. And then we'll be briefly looking at comorbidity. And then, most importantly, which I personally feel in terms of this topic, the most important part of this topic is addiction pharmacotherapy, the drugs that we use in treating many of the substance use disorders and how they lead to, or how much they are attributed for sexual dysfunction. And finally, a brief overview of management. And the last point which I've added, sex addiction, is only to state that this is not what I'm going to be talking about today. Sex addiction, though, has not been very well defined. It refers to multiple kind of problems, and we'll probably have to have a separate session on it in order to have a greater understanding of this problem. But to keep the topic relevant, sex addiction is not something which I'm going to be talking about. Now, going to the background of work which I did when I was preparing for this presentation, and the keywords which I used for identifying the literature on this topic were substance, addiction, drug abuse, sexual dysfunction, erectile dysfunction, premature ejaculation, and individual substance names in combination with the above. And most of the searches were done in either Google Scholar or PubMed. And I was able to get one full review article. I mean, there were multiple other reviews, but the full texts were not accessible. And most studies which were, and most of the individual studies which I came across were either cross-sectional, were of cross-sectional design with either self-report, and there were a few case control studies. And something which is interesting is, if you look at the chronology of the publication, until between 1970 and 1995 to even early 2000, there have been lots of publication in this area. And over the course of last a decade or a decade and a half, the number of publications have significantly fallen down. This might also suggest a little about how the pharmacotherapy which evolved over the course of 70s and 80s, including the opioid pharmacotherapy for multiple, for example, naltrexone or buprenorphine or methadone, and their link to sexual dysfunction was one of the most stimulating thing or inspiring thing for publications on this topic. And most of the studies also assess general sexual dysfunction rather than specific problems like erectile dysfunction. However, among the specific problems, erectile dysfunction was the most commonly studied. Now, looking at normal human sexuality, giving a very basic understanding, it is a combination, or it is a cycle of desire, arousal, orgasm, and in terms of sexual dysfunction, pain also comes as an important part of sexual dysfunction disorders. Now, the disorders are also classified on these domains: the disorders of desire, disorders of arousal, disorders of orgasm, as well as sexual pain disorders. However, in most classification systems like ICD or DSM, ICD does not follow a very specific trend in this kind of a classification. However, in DSM, this is more strictly followed. But substance-induced or substance-related sexual dysfunction disorder comes as a separate category in both these classification systems, and so the individual disorders in substance-related sexual dysfunction has not been very well elaborated. However, the disorders are quite the same like in the primary sexual dysfunction disorders, and the ones which have been commonly studied in relation to substance use have been: for desire it is loss of libido, for arousal it is erectile dysfunction in male and female arousal disorder for women, in orgasm again it is premature ejaculation in male and female orgasmic disorder in women, and for pain disorders it is dyspareunia, which has been commonly studied. Looking at drugs and sexual dysfunction, why is this topic relevant? Drugs act by different mechanisms, as we know, by affecting the various neurotransmitters, which is serotonin, most commonly serotonin, norepinephrine, and dopamine, and all of them have a function when it comes to normal human sexuality. And by affecting hormonal function, this is the second way in which drugs lead to sexual dysfunction. It is by altering the levels of testosterone, estrogen, or progesterone, and even the pickers are the hormones which lead to the secretion of these, like LH or FSH. And by affecting the blood flow to sexual organs is another way in which drugs and sexual dysfunction become related. Now, looking at some of the research limitations in the general overview, there are lack of controlled studies, and most studies are based on retrospective self-report. So, a bias towards reporting, as well as a bias about agreeing about a problem, is always there when it comes to the study designs. And among those few controlled studies which are available, most have been conducted in volunteering college students. So the generalizability to a normal or generalizability to a general population of different age groups might not work. And heterogeneity in the assessment tools. There have been multiple assessment tools to assess sexual function, and the tools which have been used in different studies have been quite different. And there are gender-specific physiological measures which are poorly standardized. For example, the physiological measure of erection in man and physiological measure of arousal in a woman are quite different, and they are gender-specific. So many studies have also been gender-specific, and those studies which have used both men and women will also have a methodological error when it comes to this kind of an issue. Going to the problem statement, this is again a retrospective study which was done with the ECA sample, the epidemiological catchment area study. Only the St. Louis sample of 3004 was used for the study, and it was noted that it was also, this study looked at alcohol, marijuana, and other illicit drugs, and inhibited sexual desire was not associated with alcohol or drug use. This is mostly drug use not in established dependence pattern, but on and off drug use pattern, which was self-reported by on and off drug or alcohol use pattern, which was self-reported by the sample. And so inhibited desire was not associated with alcohol or drug use. Inhibited excitement was more strongly associated with illicit drug use. Inhibited orgasm was associated with alcohol and marijuana, and painful sex was associated more with illicit drugs and marijuana. And a similar survey in Denmark for men with heavy alcohol or tobacco use, it was associated with sexual dysfunctions with an odds of varying between 2 and 22. And for women, hashish use was associated with higher risk. And another study which looked at prevalence among 105 Brazilian women. This group has separately studied women and men, and 105 women who were admitted, who were inpatients for treatment of substance use disorder. And again, a retrospective questionnaire was used for sexual dysfunction. 34.2% among them had reported of sexual dysfunction, and nicotine dependence increased the odds by nearly threefold. And other substances were not associated in this study. And education was the strongest predictor. Those who had gone ahead of the secondary education were those who had the least of sexual dysfunction. And the same group also studied 508 men, and the prevalence in them was again a similar figure of about 37.2 in a retrospective self-report. And moderate to severe alcohol, tobacco, and drug dependence was associated with sexual dysfunction. Again, in a Spanish study, this study actually was a retrospective plus prospective design, and there was no improvement noted in sexual function even after 2 weeks of abstinence, and these poor reports were persistent even beyond a period of even up to a period of 1 year. And this study by Lapera et al. Was slightly of a different design, and this is a little interesting to note because this study is about sexual dysfunction prior to first drug use. Again, in a retrospective design, 86 patients of addiction who had got admitted for treatment of addiction, and among them, only 29% prior to the onset of substance use had no sexual dysfunction, which means nearly 71% even before the first drug use reported of having one form of sexual dysfunction. And 32% of the remaining reported, 32% of this 71% reported sexual dysfunction to be one of the reasons for their first drug use, in order to lose the inhibition, in order to, with the expectancy of a better performance. So 32% of them at least quoted sexual dysfunction as one of the reasons for initiating on substances. And 50% reported continuing use to enhance sexual performance. So sexual dysfunction was noted to be a maintaining factor in at least 50% of this sample. So looking back at what has been discussed so far, the reports are fairly conflicting in the sense that some reports with patients with addiction though report very high rates of sexual dysfunction. Some of the reports have not found a significant difference in the general population, and the patterns between alcohol, nicotine, and illicit drug use do not emerge as very clear patterns in terms of what stage of sexual or what form of sexual dysfunction is affected. And a study which used only illicit drug abusers and studied for erectile dysfunction, 36.4% reported of sexual dysfunction, and odds of erectile dysfunction in heroin mono user was about 4.8, which was the highest, followed by amphetamine, which was 3.2 odds, and for MDMA it was 1.4. So some of these illicit drugs tend to have a greater propensity to cause erectile dysfunction. And sexual desire and ejaculation latency was also affected, albeit inconsistently. So with this background, what I thought was it will be useful to go through individual substances, since the studies which have generally looked at sexual dysfunction and substance use disorders have not resulted in a very clear pattern when it comes to either the prevalence or in terms of patterns of sexual dysfunction. Looking at alcohol alone, the biological plausibility of why alcohol might lead to sexual dysfunction is one, it leads to GABA-mediated CNS depression, which itself might be a cause for erectile dysfunction, as well as decreased vaginal secretion and decreased arousal response. And the acute effects of alcohol in men, at low levels, it was not found to have significant difference from the control population. However, larger the doses, more significant was the impairment in arousal and ability to ejaculate. And this was regardless of the expectation. In this study by Bredel and Wilson, they had 8 groups, and it was subdivided into 2 subgroups. In this, they had 8 groups, of which 4 groups were told that alcohol is going to increase your sexual performance, and the other 4 groups were told that alcohol would decrease the sexual performance. And regardless of the expectation, what was measured was the physiological measure of arousal, which was phenyltumescence, and that was not different regardless of whether the group's expectation was that alcohol would improve or hinder the sexual performance. Now, looking at chronic effects, unlike acute effects, chronic effects, many studies have substantially established that erectile dysfunction and difficulty in ejaculation are highly prevalent in people who use alcohol chronically, and it even worsens under intoxication. And low testosterone level, lowered sperm count, and decreased testicular size have also been noted. And though hormonal levels normalize after a period of abstinence, the sexual dysfunction continues to remain. So it is not as straight relationship between the hormonal levels and sexual dysfunction. Even if the hormonal levels get better, the sexual dysfunction remains in the same rates for long periods even after abstinence. And looking at acute effects in women, the earlier set studies were about acute effects in men, acute and chronic effects in men. Looking at acute effects in women, this has been even more inconsistent, though the physiological response has been noted to decrease. This is measured in terms of photoplethysmography, which looks at vaginal tone and vaginal blood supply during the sexual stimulus. though the physiological response decreased, many women on acute exposure to alcohol reported better arousal and better sexual functioning, even in terms of orgasm. However, in chronic effects, again in women also reported lack of orgasm, lack of arousal, and even painful intercourse, and this was significantly higher compared to the control group. Going to nicotine or tobacco, chronic use, especially more than 20 cigarettes a day, is associated with erectile dysfunction and lower testosterone levels, and it also decreases penile rigidity and penile blood pressure. In women, smoking as low as 1 cigarette a day is associated with increased painful symptoms, dysphoria, and perimenstrual problems, which is also related to poor sexual functioning during this period. Cannabis, again, acute effects in a study by self-report of 97 users, which included both men and women. 71% reported improved desire when under the influence of cannabis, and 88% reported improved sensations. However, this was only about an one-time use of cannabis or occasional use of cannabis. This was not a study which was done among people who are dependent. And again, on chronic use, both testosterone levels and sexual dysfunction, there is not very conclusive or very concrete results when it comes to chronic use of cannabis on either testosterone levels or sexual function. Coming to opioids, acute effects, again, CNS effects of morphine result in how opioids might result in sexual dysfunction. One of the hypotheses is that other than the CNS effects alone, it also leads to a peripheral vasodilation, which leads to diversion of blood flow from the genital organs, probably leading to sexual dysfunction. However, it is also described by self-reports that analgesia and delayed ejaculation by heroin motivates its usage as self-medication for premature ejaculation and dyspareunia. So again, opioids have been used as both a self-medication for the problems of sexual dysfunction, as well as they themselves can lead to sexual dysfunction. On chronic effect, what is more definitively established is inhibition of gonadotropin releasing hormone release and suppression of hypothalamo-pituitary gonadal axis, leading to decreased testosterone levels, and a general vasodilation leading to shunting of the blood. So opioids, again, on the longer run, have been associated significantly with sexual dysfunction, not as much acutely. Cocaine, again, acute effects are inconsistent. Reports are attributed to the route of usage, the route and the dosage of cocaine, and the impurities associated with impurities which are seen with cocaine use. However, spontaneous erection and ejaculation without even genital stimulation has been reported with cocaine, and occasional users report an aphrodisiac effect with cocaine. So even with cocaine, similar to cannabis, acute effects seem to be more of a positive expectation and positive desire response, and a positive even arousal response. But on chronic use, again, difficulty in erection and ejaculation which persist even long after abstinence, and cocaine and alcohol often simultaneously, the use of cocaine and alcohol simultaneously leads to a higher sexual dysfunction than either of it alone. And crack is reported to be associated with increased sexual activity, but the rate of sexual dysfunction are quite similar. Now, this is something which is related to the concept of crack itself, which comes with a lot of trading sex for buying crack, and also the context of usage of crack in many places is associated with commercial sex and things like that. So the rates of sexual activity, though they increase, the sexual dysfunction rates are equally prevalent in crack cocaine users. Looking at stimulants, again, amphetamine, acute effects, it increases libido, delays ejaculation, and impairs erection. Now, this is something which has been studied. I did not touch upon this topic in great detail, but something which has come recently in the past couple of years from studies from UK, and a large study from UK, which is a multi-center international study based on internet responses by men having sex with men. And it's an interesting concept, not just in scientific literature, but it has come out as a documentary in which is accessible. The documentary is called Chemsex. Now, Chemsex comes with use of crystal meth and use of GHB and GBL, which is GHB, GBL, crystal meth, and mephedrones. These are the 4 compounds which have been associated with chemsex, and mostly it is in men having sex with men. And the advantage of this is that there have been a couple of terms which have been described in more popular literature, which is like instant bottom and a crystal dick. Now, what this does is it delays ejaculation. The erection is not complete, but it is sustained, and so it leads to a longer duration of sexual activity, and it also leads to relaxation of the relaxation of the anal sphincter. So this has been something which has been quite prevalent from 2010 onwards, and many studios which have this kind of where sex comes to be associated with use of chemicals with it, and a lot of side effects related to that have been studied, and nearly about 1/5 of men who are having sex with men reported to have been using one of these drugs in order to improve the sexual activity. And again, chronic use of stimulants in men again leads to, compared to cocaine, it seems to have a better long-term profile. However, even this has similar effects on sexual dysfunction. Looking at other illicit drugs, PCP seems to have minimal effect on acute use, and long-term use results in decreased libido, which is supposed to be secondary to limbic dysfunction. LSD, there have not been many controlled studies on sexual function. MDMA, which was initially introduced as a love drug, which was to increase the sensual experience rather than the sexual functioning per se. However, on chronic use, it is also again reported to have similar effects as the other stimulants like amphetamines. And volatile nitrates, which is basically used among this particular population which is associated with commercial sex as well as men having sex with men, in order to achieve a better erection and longer duration of erection, has also been another drug of abuse which we do not commonly see in other commonly see as a part of other substances of addiction. Now, GHB and GBL again have an effect of losing inhibition, improving the sexual functioning, and improving the intimacy and improving empathy when it comes to sexual function. So these are again which have been popular as date rape drugs, are also very commonly used in population where in a particular population like I described in chemsex. One thing which is important when we are dealing with this problem of sexual dysfunction and substance use disorder is the concept of comorbidity. Now, we see that the depression or anxiety disorders are highly prevalent in both these populations, and the contribution of depression as well as anxiety disorders will also have to be kept in mind while we are dealing with a patient whom we are treating for substance use disorder who comes with the problem of sexual dysfunction, because unless they are attended to and treated, the problem might never be solved as so long as we are changing the pharmacotherapeutic agent which we are using as an anti-craving agent or for a maintenance treatment. Secondly, the medications which are used for these comorbid conditions are commonly associated with sexual dysfunction. The rates go up to 70% with SSRIs. So even this will have to be kept in mind while treating people with sexual dysfunction in substance use disorder. And sexual dysfunction itself could be an initiating and maintaining factor along with anxiety and depression for many of the substances of abuse. So these are the 3 things which will have to be kept in mind while we look from a patient's perspective when we are treating SD in the context of substance use disorder. Now, looking at addiction pharmacotherapy, as I initially said, which I consider at least the most important, because many patients do have a common notion, and it is when they also talk to each other, this is something which many patients come and report that my friends have told me that the drugs which you are giving leads to sexual dysfunction. Should I be continuing it, or can I go off medications? So many people come up with this kind of an apprehension, and which is also quite genuine. If we look at the sexual dysfunction, the most common medications which we use, whether disulfiram, naltrexone, acamprosate, baclofen, topiramate, buprenorphine, or methadone, all of them have almost all kinds of sexual, all of them have at least to an extent been reported with some form of sexual dysfunction. Now, if we look, it depends on the way in which we look at literature. If we start reading literature about drugs causing sexual dysfunction, most of the time we either note disulfiram to be noted there, and rarely and all disulfiram and also the opioids being noted there. However, if you look at individual drugs and whether they have any sexual dysfunction effect, almost all drugs have some sort of sexual dysfunction, either as a rare or uncommon side effect. Now, disulfiram has been strongly established, as I said, with impotence, decreased arousal, and desire. Naltrexone has some conflicting data, and I've not been able to resolve it with my literature search. When it initially came in 1980s, there were a few studies which used naltrexone in order to improve sexual activity in even people who did not have substance use problem. It was used as a treatment for primary sexual dysfunction earlier in order to stimulate sexual activity in men, and it led to no changes in FSH, LH, or testosterone. However, naltrexone has also been reported to have all the above which were noted to be with disulfiram, which is impotence, decreased arousal, and desire. Acamprosate has been commonly associated with impotence and loss of desire. And baclofen, again, because of the GABA action, again has been reported to have decrease in libido and inhibited orgasm. Inhibited orgasm is something which has been more commonly noted with baclofen compared to libido or arousal. Now, topiramate is, again, because it was an anti-epileptic, the number of studies on topiramate have been quite high, and multiple mechanisms of erectile dysfunction have been reported with topiramate, which could be starting with CNS action as well as local vasogenic effects on the genital organs, and also the newly identified AMPA and NMDA receptors in the lumbosacral plexus, which itself depend on sodium channels, which themselves depend on some sodium channels, also seem to be their activity also seem to be impaired by topiramate, and so topiramate can lead to erectile dysfunction through multiple mechanisms. Now, buprenorphine and methadone, which I'll review in little more detail, because one of the common problems, whether it is with use of opioids as drugs of abuse or use of opioids as part of treatment, whether it comes to chronic pain or whether it comes as a substitution therapy, one of the common problems is about the sexual dysfunction they cause. So, premature ejaculation, erectile dysfunction, loss of libido, and all have been noted with buprenorphine, but there is evidence which I'll quote next, which says, which it seems to be less severe than that with methadone, and methadone again has all these sexual dysfunction problems. Now, in a study of methadone maintenance and sexual dysfunction, global sexual dysfunction was noted to be similar to general population in this particular study in 2008. However, it had higher orgasmic dysfunction, and the orgasmic dysfunction had higher direct correlation with the dose of methadone which was being used, and this is not associated with plasma testosterone or prolactin levels. And in a very early study in 1975, which used more of say the histological and physiological measures, there were decreased seminal, vesicular, and prostatic secretion, which was noted in people who were on methadone, and there was 43% reduction in testosterone also, which was noted. Buprenorphine seems to have a lesser testosterone lowering effect compared to methadone, probably hypothesized to be due to its differential receptor profile. And in a study which compared methadone and buprenorphine by Hallinan in 2008 to 2009, there were, on the same sample, the two studies were published. 28% were noted to have a sexual dysfunction with buprenorphine group, compared to 65% who were on methadone. And 9 out of the 10 cases of buprenorphine-related sexual dysfunction had low testosterone levels, and topical application of testosterone gel up to 5 mg per day improved sexual functioning in almost all the patients who had this issue. Now, quickly going through the management for sexual dysfunction. Now, there was no literature which studied sexual dysfunction in substance use disorder as a separate entity for treatment. So, the general principles which are applied in sexual dysfunction as a primary problem will also have to be applied in management of patients who come with substance use disorder and sexual dysfunction. Going to the assessment before going to the treatment part, the assessment of sexual dysfunction, there have been various scales. There are more than about, if we look at the literature, there are more than 100 scales which assess this problem. However, I have quoted only a couple of, or 2 or 3 of them which have been used in some of the Indian studies, and which have also which are also easy to administer and which we can clinically make use of in day-to-day practice. The first scale is about Arizona Sexual Experience Scale. It is validated for, it was initially designed and validated for psychotropic drug-induced sexual dysfunction. To start with, it was SSRIs, then it has been used in schizophrenia, schizoaffective and all mood disorders as well. It has just 5 items, and each of these is assessed on a 6-point scale, varying from 1 to 6. 1 suggesting hyper-functioning and 6 suggesting poor functioning, and a total of 19 or more. The total score of 19 or more, or 1 item with a score of greater than or equal to 5, or 3 items with a score of greater than or equal to 4 will indicate sexual dysfunction. This again assesses sexual dysfunction in the domains which we discussed earlier, like desire, the orgasm, the desire, arousal, orgasm, pain, as well as there's one more entity about the duration which was taken for ejaculation or orgasm. Now, so that way in this scale is quite informative, in the sense we will also be able to know the type of sexual dysfunction which the patient is coming up with. Now, sexual functioning questionnaire again has been validated for Indian population in a recent study of 2014, and a cutoff of 14 has been established for Indian population. For this study has been done from TGI, and cutoff of 14 has been established to make a diagnosis of sexual dysfunction. Now, sexual dysfunction checklist. This was the study. This was the checklist which was designed in the initial study with which I opened today's presentation, which was done in our center. 12 items have been generated based on ICD-10, and all the domains of sexual dysfunction according to ICD diagnosis are used in this checklist. And this checklist is also quite simple, and since it also helps in making a ICD-10 consistent diagnosis, this can also be used for assessing our on bedside whether our patient is having any sort of sexual dysfunction. Going to the approach for sexual dysfunction itself in a patient who is with substance use disorder and who has come to the who has been on treatment for some time. Some of the considerations which we'll have is, first of all, we'll have to start with a detailed history to ascertain the nature of the problem, whether it is related to desire or arousal or orgasm, or whether it is a pain disorder. Secondly, the onset of the problem, whether it was before the use of drug or whether it was after long-term use of drug, or whether it was after initiating a pharmacotherapy for addiction, and whether there are any contributing physical and psychological issues, which is also the case when it comes to assessing any patient with primary sexual dysfunction. Now, as I said, the dose reduction in the anti-craving agent, which we have been either an anti-craving agent or a maintenance treatment, which we have been which has been initiated. Dose reduction is the first option, which has some evidence about improving the sexual functioning. Changing over to an alternate agent is another option which we'll have to consider. However, for any kind of erectile dysfunction, after ruling out the physical causes and after ascertaining the physical causes, unless the patient is on nitrates, there is no contraindication in giving phosphodiesterase 5 inhibitors, which is sildenafil or velodalafil, which are commonly tadalafil, which are commonly available. And when there is no response to PDE5 inhibitors alone, a combination of phosphodiesterase inhibitor and PGE1, which is alprostadil. Alprostadil combination with tadalafil or sildenafil helps in most patients. And if there is no response to each of this, we might have to require a specialist referral to rule out whether there are any vascular or whether there are any primary neurological problems which needs to be identified. And for premature ejaculation, an off-label use of low-dose SSRI or clomipramine definitely helps in many patients, and up to 60 to 70% of the patients with premature ejaculation. However, with this problem, therapy will also have a greater role, and both for premature ejaculation as well as erectile dysfunction, psychotherapeutic interventions in combination with pharmacotherapeutic agent will have better outcomes, which has been established in primary sexual dysfunctions. Now, to summarize what has been discussed so far, most of the earlier things which we discussed about acute and chronic effects of each substance I consider them to be of use when it comes to a patient who primarily presents to us, and their reason for continuing the substance or initiating the substance was to enhance sexual function. Since the studies over the last 5 decades have conclusively established that on chronic usage, almost all drugs lead to a loss of desire, loss of arousal and orgasm. So at least in terms of one of the educational interventions during motivational interviewing, this can be used, and it can also be used to clarify the myths which the patient might have about sustained improved sexual functioning with continued use of drugs. Secondly, in terms of treatment, all the medications which are prescribed in terms of anti-craving agents or maintenance agents seem to have some sexual or at least one sexual dysfunction as a side effect. So it is good to consider that in an interaction with the patient, rather than being defensive about it and being open to either reducing the dosage or changing the medication, or even to add on another pharmacotherapy like for erectile dysfunction, will benefit in keeping our patients in the treatment as well as maintaining them on long-term pharmacotherapy for addiction itself. These are the few references which I have taken, and thank you.
Any clarifications and suggestions?
I wish you have given, what is the percentage of erectile dysfunction or premature ejaculation for each of the drugs, starting from disulfiram to buprenorphine or methadone. I wish you do that. And also I wish you do what is the kind of dose reduction and what kind of result it has affected.
Yeah.
Because that would be a very useful thing. Whether instead of 250 milligram, 125 milligram of disulfiram will be helpful. And buprenorphine, whatever we have calculated the dosage, whether half the dosage, whether it will be helpful, because this is very important to keep them in the treatment loop. Thank you.
I mean, since I went by a very evidence-based approach, I only looked at articles which had evidence for this. And thankfully for disulfiram, there is still evidence which says that continuing at 250 milligrams instead of a higher dose of 500 milligrams is reported to have a lower sexual dysfunction profile. However, even at 250 milligrams, there were a substantial proportion of the patients who were on it who reported to have sexual dysfunction. So with disulfiram, there is such evidence available. But in terms of other drugs, I was unable to, since what happens in most of these studies are that they compare a drug with a placebo, and the placebo and drug comparison is mainly done for efficacy and the other problems. When it comes to slightly less common side effects, but what I can say in general, as a general rule of thumb, is for almost all the drugs other than methadone or buprenorphine, the percentages are less than 5. And that is one of the reasons why it is not reported, or which is not primarily compared with placebo when it comes to these placebo controlled trials. Since there is one online software available called Cider X, which looks at all the placebo controlled studies which have been done so far on each agent, whether it is the agents which we discussed here or any agent, and looks at what has been compared in the placebo controlled design. And many of these drugs have not really had that kind of a comparison with placebo when it comes to how much is the percentage of sexual dysfunction. And coming to dose reduction, as I said, for disulfiram, there is some evidence on lesser sexual dysfunction with 250 milligrams. But for other drugs, for example, since the drugs themselves are not so well established in terms of, for example, either for baclofen or topiramate as an indication for anti-craving agent, the dosages have not been really established as of now.
Just to add on the fact that
Thank you.
Normally with the patients we see in our clinics, as you know, most of us see, we don't actually come across a significant increase in when seeing people complaining of the sexual dysfunction. We specifically ask the opioid users, definitely most of us ask, because opioid is well known to cause sexual dysfunction, and there are young people also. Disulfiram, although as been told that it has been one of the notorious agent for sexual dysfunction, but still in my experience of giving disulfiram, so many patients I hardly come across, although I ask them they have sexual dysfunction, but less. Other drugs are definitely far less than the like meclofenacum, naltrexone, far less than this thing.
With regards to opioids, there are some evidence which suggests that like there is no dose dependence in these side effects as such. Like, I am not able to quote whether it was done for. It was generally common that opioids and sexual side effects are not or dose independent per se, and not. It doesn't vary with the dosage as such.
The Suhas question is, what should your response when patients on buprenorphine ask about side effects? Now, I think normally when you start buprenorphine, you may or may not go to discuss about sexual dysfunction if it's already not complaining. Now, we have a couple of patients who did complain of sexual dysfunction and you did get a testosterone level, and now this is almost zero. I mean, one patient I remember very well, his testosterone came out zero. I mean, it was unusual young man having zero testosterone, and then we told him, see, because you are using street heroin, has gone zero. Then we started basically replacement therapy, and his testosterone improved, and obviously sexual function has improved down the line. So I don't think at the outset you need not have to discuss these issues at the upfront knowledge. He tells about that I have sexual dysfunction, and in our experience, it's not very common. People talk. But what is good that before is part of the history to check. I mean, do you have a sexual dysfunction? It's good to do, because otherwise opioid and sex has a very good, very close relationship in that way. Delayed ejaculation, expectation of having a better sex. So those erroneous myth has to be broken somewhere down the line. So that's good to ask, but not always that you will deliberately tell that because you're buprenorphine you have to have sexual dysfunction. It doesn't work. So I don't think so. I mean, you're right, sort of telling that. We need not to discuss in each session. This is my view.
But most of studies do say that like it has to be monitored regularly. Almost all the studies which have been done on MMT or BMT has said that like it has to be evaluated consistently and documented.
Particularly in the street heroin cases, that's very common. I mean, there's one thing.
Yes. Something which is interesting in this regard was that the study compared buprenorphine, methadone, and street heroin users. The rates of sexual dysfunction were least in buprenorphine, in between in street heroin, and highest in methadone.
Again, some of these studies were. It said that like people who have regular sex partners had a lesser sexual dysfunction when compared to people who don't have a thing.
Yes.
Some of the studies which you have quoted, one part of them talks about methadone, people who are an MMT who had regular sexual partners, people who have an BMT who had regular sexual partners. They could find difference between when there is a regular sexual partner also there is no the sexual side effects are lesser.
Okay, I think it's already time. It's 4 o'clock, so let's stop it here. I know there was a lot of questions. Please don't hesitate to send us by email if you want to ask anything. What was surprising to me when I was looking at these slides and think that in our clinic itself, we have 70% of people who complain of sexual dysfunction in alcohol dependent. The study we started. I mean, we also asked ourselves that because of various reasons, we normally don't discuss the cases, discuss the sexual functioning unless they bring it up. Well, it's learning from all of us that we need to somewhere down the line ask about the sexual functioning, which is a part and parcel of the people having substance use disorder. But people having substance are also very young. They're young, they're active. So you need to ask and discuss whether what happens, the outcome is different. But discussion definitely decreases a lot of difficulties. So I think I will stop here. Okay, thanks to all of you.